नहीं नहीं वो मतलब तो नॉर्मल वालों को कौन सा? हाँ ये
चेक हेलो 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 हेलो
ये देख
खोल
ये वाला है।
हेलो हेलो हेलो
हाँ
हेलो
इंडिया टाउन वाला।
हेलो हाँ ठीक है हेलो
ओपन कर
हेलो
ले।
चेक हेलो
जो बाहर था ना वही ले लेना, वो मत ले लेना। तो डायरेक्ट पेन ड्राइव से लगा रहा है क्या? हाँ कॉपी कर ले। वो कर ले। हाँ भाई कुछ चेंजेस मत। हाँ छोटा ही है, टाउन हॉल बड़ा रहेगा 1 घंटे का। हेलो 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 अरे हेलो हेलो ओके कुठे कॅफेटेरिया? हाँ कनेक्ट करा. हेलो हेलो केला कनेक्ट कनेक्ट केला का? चला टीव्हीवर. हॅलो हॅलो कनेक्शन झालं का? अरे उनको बन गया, बफर हो रहा है. स्टॉप हुआ था अभी 2 सेकंड के लिए. नहीं यहाँ पर स्टॉप हुआ था, यहाँ पर. हाँ अरे इधर गई तो वाईफाई है. कहाँ? हाँ वो चेक कर रहे. नहीं हाँ बता रहा हूँ मैं. साला इधर मोबाइल का भी नेट नहीं मिलता है. फास्ट बहुत है. हाँ हेलो ये वायरिंग ये करना था. हाँ हेलो 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 माइक टेस्ट. हेलो हेलो वॉइस क्लियर है क्या संजय सर? हेलो 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 साला नेट ऑफ है. ये पॉइंटर दे. लगा है पॉइंटर? इसमें लगा दे. बोलो उसमें. हेलो देखना होगा, ये वहाँ पर चेक करना था मुझे, रेंज चेक करना। हेलो संजय सर, ओके। ये क्या बाहर क्यों गया? F5 मार। करो अरविंद। हेलो माइक चेक। ओके ठीक है, ये मिनिमाइज करके रखना। हेलो संजय सर, हेलो हेलो। हॅलो, व्हॉइस येते तुम्हाला? चालेल, करून घ्या। तुमच्या लॅपटॉपवर येतोय का? तुमच्या लॅपटॉपवर येते का? चालेल, आणि मला जरा चॅटची लिंक पाठवून द्या, चॅट लिंक। हॅलो, नाही इकडे नाही नेटवर्क भेटत, एअरटेल आहे फक्त। चॅटची लिंक पाठवून द्या मला जरा स्काईपवर, चॅट करण्यासाठी। तीच आहे? ओके चालेल, चेक करतो मी। चला बाय। ओके ओके। आपण हॅलो संजय सर, चॅट कुठे ओपन करू? मी माझ्या लॅपटॉपला ओपन करू की कोणत्या लॅपटॉपवर? ओके चालेल। नाही नाही नाही, ते नाही बोलत आहे। जर आपल्याला आपला कसा माझ्या लॅपटॉपवर मी हे केलं आहे, तुम्ही जे करता ना, तुम्ही बसता ना तुमचा लॅपटॉप घेऊन, तसा मी लाईव्ह वेबकास्ट करतो आहे मग। हां ओके Hello. Hello. 1. Hello. 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 Mic check. Hello. Hello. अरविंद वीडियो प्ले करो ना लाइव पे. तेरे पास रहेगा ना कोई तो डाल. हेलो. माइक चेक. हेलो. 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 माइक चेक. हेलो. नहीं नहीं वो मैं सिर्फ चेकिंग के लिए कर रहा था. कोई वीडियो प्ले लास्ट टाइम मुंबई में कंजम्पशन हुआ था, बफरिंग हो रहा था. हेलो. इनकेस कोई वीडियो प्ले होता तो प्रॉब्लम हो जाता यहाँ पर. हेलो. 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 माइक चेक. हेलो. हेलो. माइक चेक. हेलो. 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 1 मिनट. ये देना. हेलो. 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 चेकिंग. हेलो. हेलो. वीडियो किया प्ले. हेलो. 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 माइक चेक. हेलो. 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 हेलो.
And one can see that there is a shift to the left, so we are diagnosing more patients at an earlier age. And that is something we need to understand, and our strategies over the future will have to be tailored and would have to be designed around this fact that the younger women would need a different type of an attention and also a different type of the workup at the time of diagnosis and during the follow-up. Now, let's look at the projection of breast cancer burden in India. And one can see through the last about 7 to 8 years, beginning 2011, and the numbers, as I said, are about 150,000 per year. But the disturbing trend is that by 2026, this would cross 200,000, and the burden is only going to rise, which is in consonance with the trends we know that by 2030, 2/3 and almost about maybe more of the cancer cases are going to come from the developing and the underdeveloped world, and we are part of that. And therefore, the burden is going to pose a bigger challenge in terms of the lack of screening facilities and also the lack of the geographic distribution of the cancer centers in India and the access to care and the access to a good follow-up and survivorship. So, having said that, let's look at the targeted therapies in HER2 positive cases and the different settings as I outlined in the initial slide, that we would look at the neoadjuvant setting, the adjuvant treatment, and look at the novel anti-HER2 agents and immunotherapy. So, neoadjuvant treatment of HER2 positive disease is emerged as one of the very distinct entities where the impact has been realized in a big way. And In the preoperative or the adjuvant setting, if we look at the various regimens which are available to us, the two most powerful agents are the anthracyclines and the taxanes, and we would combine them in some way or the other or use them sequentially, because HER2 neu is inherently a high risk disease and needs to be treated with the best agents up front. The NCCN guidelines of 2018, they outlined the preferred regimens as one of the anthracyclines, which could be doxorubicin cyclophosphamide, followed by taxane, and which could be paclitaxel plus trastuzumab, or the combination of the taxane and carboplatin with trastuzumab upfront, which is the TCH, which we got to know from the BCIRG 006 trial. And of course, there is some now talk about addition of pertuzumab to the adjuvant setting. So principally what we are talking about is using the best agents upfront: anthracycline, taxane and trastuzumab. There is total agreement and a wealth of data which is available on this subject. In short, trastuzumab in combination with chemotherapy is the preferred therapeutic option. Today one would not think of a non-trastuzumab regimen for a HER2 neu positive disease. How about adjuvant setting in an hormone receptor positive? Now, hormone receptor positive, one would divide the disease into two groups. One would be the node negative and the node positive disease, and depending upon the size of the tumor, whether that is less than 0.5 centimeters, which is a very initial disease, or 6 millimeters to 10 millimeters and then beyond, these are the three categories. One could, in the first category, very small tumors, in an appropriate setting, just choose a hormonal drug, endocrine therapy, alongside trastuzumab. But however, in the larger tumors, one needs to look at the other parameters, patient preferences, and the resources available. So one could consider chemotherapy also in this group, and obviously trastuzumab remains as one of the main drugs alongside. In node positive disease, there is very little discussion about the choice of treatment, and HER2 neu disease being a high risk, as I said earlier, there is a need to use adjuvant chemotherapy with trastuzumab, which is listed as category 1, and of course followed it up with endocrine therapy in the appropriate setting. Whether the woman is premenopausal or postmenopausal, one would choose the hormonal therapy. In short, again, adjuvant trastuzumab with endocrine therapy plus minus chemo in HER2 positive disease, and which is also hormone receptor positive, this is the preferred choice. How about the hormone receptor negative? This lends a bit of a more aggression to these tumors, and one would choose the treatment based on the node positivity versus the node negativity again. And essentially what we are talking about, because there is no hormone receptor, there is no target to be considered, most of these women would be considered for a backbone chemotherapy and trastuzumab. The choice of chemotherapy would depend upon the patient preferences, patient parameters, and other host factors and the comorbidities. But there is hardly any doubt that most of these individuals would go for chemotherapy plus trastuzumab, barring very small tumors which are 5 millimeters and below. Again, in summary, adjuvant chemotherapy with trastuzumab is the preferred choice in hormone receptor negative and HER2 neu positive disease. Now, how about a recurrent or a metastatic setting where the HER2 is positive with prior endocrine therapy? There would be a setting, because those in the initial treatment may not have received any chemotherapy or any other drug other than the endocrine therapy. So here one would stratify these women based on their menopausal status, be it premenopausal versus postmenopausal, and one would still consider doing an ovarian suppression based on how extensive the disease is and where all the disease is sitting, and is there a visceral crisis or there is no visceral crisis, and how soon we want the effect of the drugs to kick in. So the choice would rest on ovarian suppression plus the therapy as for postmenopausal women. And what would be the therapy for postmenopausal women? One would consider doing chemo backbone with another targeted HER2 therapy, or give them TDM1, or continue trastuzumab plus chemotherapy based on the length of the treatment-free interval from the previous medication. Now, in the setting where a woman hasn't received any prior endocrine therapy, so therefore this would be a setting which would be again applicable to ovarian ablation or suppression plus therapy as for postmenopausal women, if we are talking about a premenopausal women for selection of this therapy. And HER2 directed therapy would again remain one of the backbones, and one could choose another drug, dual drug, or TDM1 depending upon the setting we are talking about. In the postmenopausal, of course, another aromatase inhibitor, if one has used a non-steroidal, one could choose a steroidal like an exemestane, or sometimes even the other ER modulators alongside HER2 directed therapy. And of course, TDM1 and as well as the other HER2 pertuzumab would remain one of the other drugs based on the treatment-free interval the woman has enjoyed from the previous lines of therapy. Now, when there is a progression following the first line of the HER2 positive disease, now if there is a progression of first line endocrine therapy, one could still consider an endocrine therapy if not endocrine refractory strictly by definition. And also one will have to take into consideration the presence or absence of disease in certain areas of the body, and how soon we are wanting to affect a response. That goes to say, are we dealing with a visceral crisis or not? But we know that progressively the benefit of endocrine therapy is that wanes away, and one does not accrue much benefit in these individuals once more than three sequential endocrine therapies have been used, and these individuals actually, truly speaking, would go on to some sort of a clinical trial if the facility or the opportunity exists. Now, if the progression on first line therapy plus HER targeted therapy is there, one could continue the HER2 directed therapy as we were using in the previous line, or and at the same time one could change the endocrine therapy and of course see the spread of the disease and the presence of disease in which areas it sits in the body system. And as I said earlier, the point is being reiterated again that more than about 3 lines cannot benefit, but one should continue. The strong message is the anti-HER therapy should be continued until disease progression. There is elegant data from the last decade to show that if you stop the HER directed therapy, there may be a very sudden rise in the treatment in the tumor progression, and it suddenly just literally takes a vertical takeoff, and one should continue to use the HER2 directed therapy even beyond progression. Now, in the neoadjuvant setting, as I said earlier, this is one of the strong areas in the neoadjuvant setting which has emerged over the last decade and a half. And what underlines the premise is the achievement of a pathological complete response, and this has become a measure of efficacy of neoadjuvant treatment. It's a FDA approved endpoint for neoadjuvant therapies, and this is strongly considered an important prognostic factor. I would show you in one of the subsequent slides how that happens, and it is associated with a survival advantage in the neoadjuvant setting. PCR now has been adopted as the primary endpoint for neoadjuvant trials, and almost about 70 to 80% can achieve some sort of a PCR treated with the trastuzumab in the appropriate setting. This has become a surrogate endpoint for prediction of long-term clinical benefits, such as both the disease-free as well as the event-free survival, and also in the overall survival setting. So that is something strong point about the neoadjuvant setting, and this slide shows you what is the difference between the pathological complete responders versus the non-responders, and one can see that the Kaplan-Meier curve, the
check, hello, check, check,
Hello, mic check.
hello, hello,
Hello,
check, hello,
hello,
check,
hello, check. Hello, hello, hello. Wait. हा बोला.
अरे ते तुझ्या मोबाईल मध्ये नीट आवाजच येत नाही.
नाही नाही ते इकडे नेटवर्कचा इश्यूज आहे.
मग कोणाचा रमेश येईल ना नंतर. आता का रमेश तिकडे आहे का?
हा रमेशचा पण इश्यू येणारच. मोबाईलचे प्रॉब्लेमच आहेत.
नाही बरं त्या दिवशी आपण टेस्टिंग करत होतो तेव्हा रमेशला प्रॉपर जात होता.
तेव्हा येत होता प्रॉपर, पण नाही मध्ये मध्ये तो डाऊन होतोय. एक काम कर ना, एक मिनट संजय सर. हाँ हेलो, ये नीचे डालते ना उसके. ये उठाओ ना. अरे यार एक मिनट उसके नीचे डाल दो. हेलो, और ये भी थोड़ा, नहीं तो ये थोड़ा इधर खींच लेना. ये ले लेना, उड़ा ना, कारपेट ठीक करने बोलो. हेलो हेलो चेक. हेलो.
हा बोल ना.
ओके ना, ते कार्पेट आणि लावून घेतोय HSAC.
हा ठीक आहे ते करून घे. आणि
ओके.
दुसरं पीपीटी आणि प्रोजेक्शन वगैरे काय कुठे लावायचं ते झालं का तू?
हा झालं माझं, कन्फर्म करून झालं मी. एक रमेशचा लॅपटॉप घेतलाय विंडोज 7चा. ओके, त्याने प्रोजेक्शन करतोय, त्याला नेट नाही, बंद करून ठेवलंय. ओके, आणि माझ्या लॅपटॉपवर चॅटिंग आहे.
ओके. आणि पीपीटी जसं तू लोकली त्या लॅपटॉपवरच मुवमेंट करणार तुम्ही?
हा लोकलीच. येस.
आणि तू जसं लोकली तिथं पीपीटी मूव करणार तसं ॲज इट इज त्याच वेळी तू वेबकास्टवाला करणार?
हा ते अरविंदच्या इकडेच आहे. लोकली जो आपला लॅपटॉप असतो ना तो पण अरविंदकडेच आहे सेम, आणि त्याचा लॅपटॉप तिकडेच आहे. अरविंदच्या टेबलवर होणार जे काय होणार ते.
आणि म्हणजे प्रेझेंटर आहे ना, म्हणजे
हा स्लाइड चेंजर अरविंद घेऊन आलाय. ओके.
आणि मग स्लायडर त्याला देणार आणि मग स्लाइड तो चेंज करत राहणार.
हा ते बघ.
त्या हिशोबाने तो वेबकास्टवाला पण चेंज करतो.
ओके ओके चालेल. ते हा तसंच सेम.
ठीक आहे.
ओके.
काय दुसरं जे काय होतं ते सगळं लावलं?
कोणतं?
आणखी काय होतं ब्रँडिंग वगैरे?
ब्रँडिंग अजून बॅकड्रॉप आलाच नाही माझ्या इथे.
ठीक आहे. तसा तो आपला लुकआउट नाहीये.
नाही ना, तो लुकआउट नाही आपला.
ती काय बोलली का?
नाही अजून काही कॉलच लागत नाही.
म्हणजे जो वेंडर जो कोण असेल तो
नाही त्याचा कॉल लागतोय, पण माझा प्रणितेचा कॉल लागत नाही. ती त्यांचं लंचचं बघते आता.
आता काय राहिलं पेंटिंग? फक्त बॅकड्रॉपच राहिले.
हा बॅकड्रॉप आणि जरा HSAC कन्सल्ट सगळ्या वायर हे करून घेते मी.
आता तुला तर तेच करायचं आहे.
ओके
ठीक आहे. तू आता करून घे. आपण एक 2:30 वाजता परत एकदा रेडी करू. सगळं फिक्स करून टाकते काय असेल ते.
ओके ओके चालेल.
ये आता तो डिस्कनेक्ट कर. वेबकास्ट डिस्कनेक्ट कर. बाकी टॅगिंग केबल टायमिंग हे जे काय
ओके ओके
सगळं पार्ट क्लिअर कर आणि मग 2:30 ला आपण कनेक्ट करू परत.
ओके चालेल, नो इश्यू.
आता 2 तास जे काय ते तू करून घे. लंच बी त्याच्यात 2:30 पर्यंत.
नहीं चाहिए. इंडियाला भेटला तर कुठेतरी चाम ठेवीन तुला. चला ओके.